Sir, please start in 3, 2, 1. Please start, sir. We are live.
Good evening, one and all, all the delegates. My name is Satish Rama Joshilkar. I am from Zydus head Office. I would like to welcome all our delegates for today's Clear Talk, and I would like to welcome our today's eminent speaker, Dr. Nitin Bote, sir. So today's talk, just to give brief about Clear Talk. Clear Talk is one more facet to unite against dyslipidemia. The recent development in the field of dyslipidemia management is bempedoic acid and clear outcomes trial, which was presented in recently ACC, American College of Cardiology. We have one of the best faculty here, Dr. Nitin Bote, sir. Would like to give a brief introduction about sir. Sir is consultant interventional cardiologist. Sir is attached to Nandini Heart and Child Care, KJ Somaya Hospital, SL Raheja, and many hospitals in Mumbai. Sir is assistant professor in Department of Cardiology, JHN Group of Hospitals, Mumbai. He has independent more than 10,000 angioplasties. His special interest is coronary interventions, complex angioplasty, experience in IVUS, OCT, etc. Sir has research experience more than 10 papers in journal, in national publications, as well as international publications. Sir has also presented paper in CSI. So without wasting much of our time, would like to hand over this session and today's topic, bempedoic acid through the lenses of clear outcomes trial. Over to you, sir.
Thank you, Zydus. First of all, I would like to thank Zydus for giving me this opportunity. Good evening, everybody. A warm welcome. I'm Dr. Nitin Nanasaheb Bote. I'm an intervention cardiologist practicing in Mumbai. I have been practicing in Mumbai since last 10 years, and I'm doing all types of angiography, angioplasty, and even cardiac consultation. So today we are going to have an interesting talk about lipid profile. Recently, there was clear outcome trial about bempedoic acid. Next slide. So we all know that LDL is the main factor which causes heart disease, ischemic heart disease, and MI and ACS, all that. So main concept which is available is LDL, which is lower the better. So relative risk reduce 1 millimole per liter reduction of LDL will lead to 23% decrease in total risk. So what are the drugs available? We have got ezetimibe, fibrate, niacin, diet, statins, bile acid sequestrants, ileal bypass, and recently in the chain is PCSK9 inhibitors. Next slide. So 1 millimole of reduction in LDL will give to more cardiac events reduction according to number of years in trials and comorbidities as well. So 1 year in trial will lead to 11% reduction, 2 year in trial will lead to 24%, 3 year in trial lead to 33%, and more than 6 in trial lead to 36% reduction. Next slide. So management of dyslipidemia means high cholesterol is basically on priority, and statins are the first line of choice. But do all statin users achieve LDL goal as per guideline recommendation? And how to achieve LDL target after maximally tolerated dose of statin? If you are giving maximal dose of statin, how to tolerate the dose? Okay, do all statin users achieve LDL goals as per guideline recommendation? Next slide. So LDL target is based on risk stratification of this CVD risk factor. So we have to calculate ACVD risk score, and according to that, there is a major ACVD, then there is low risk, moderate risk, high risk, very high risk, and extreme risk group of people. Next slide. So LAI, that is Lipid Association of India 2020, revised LDL target for an Indian population. So extremely risk category, we have to reduce LDL less than 30, very high risk, reduce LDL less than 50, high risk, reduce LDL less than 70, Moderate risk reduce LDL less than 100. Next slide. So low risk ESC says LDL should be less than 115. Moderate risk LDL should be less than 115. But in high risk patient, LDL should be less than 70. Very high risk LDL should be less than 55. Next slide. So based on revised ESC 2000 guidelines, how many of our patients achieve control LDL? Okay, next slide. So European wide cross-sectional observation study of lipid modifying therapy used in secondary and primary care Da Vinci study. Total number of patients were 5,000. Primary prevention was achieved in 3,000. Secondary prevention was achieved in 2,800 patients. Next slide. So Da Vinci study overall outcome, the proportion of patients who received LLT was only 27.6%, and 27.6% were eligible after receiving high intensity statins, and only 30% achieved goals. Next slide. So Da Vinci study showed that 37.5% eligible patients are receiving high intensity statins and percent lipid goals with high intensity statin. Next slide. So concern 2, how to achieve the LDL target after giving maximally tolerated dose of statins. How to achieve that? Next slide. So we have got checklist of familial hypercholesteremia, complete statin intolerance, SCVD risk. So does the statins are very effective in very high risk patient? Next slide. So high intensity statins, there is very low adherence which lead to higher MACE. Observation study of 20,000 patients said that only 64% of the all patients of SCS did not take high intensity statin after discharge. More than 50% of the patient had drug interruption, and non-adherence lead to high MACE rate. Next slide. So bempedoic acid, that is ATP citrate lyase, it is a newer drug, first in class, first drug. Reduce uncontrolled LDL with maximally tolerated statin dose, and statin intolerance in whom the statins are contraindicated. The dose is 180 milligram orally with or without food. Next slide. So unlocking. First is US FDA approved, given in February 2020. EMA approved given in March 20. Then CVOT trial given in March 23. Next slide. So bempedoic acid acts on ACL enzyme, that is upstream to HMG-CoA reductase, and bempedoic acid is not activated in skeletal muscle, so it is not expressed in muscle, so it doesn't cause muscle pain. Next slide. So the half-life is 21 years. Elimination is mainly through kidney, and less than 2% excretion unchanged through kidney. Next slide. So the CLEAR outcome trial, the cholesterol lowering via bempedoic acid in an ACL inhibiting regimen. It is a late breaking trial. Next slide. So CLEAR outcome showed that the patient who was statin intolerant and patient were given bempedoic acid versus placebo, and total 13,000 patients were enrolled. Median follow-up was 40 months. Next slide. So background. Basically statin tolerance occurred in 15% patient, and ATP citrate lyase inhibitor is bempedoic acid. So CV outcomes not assessed. Next slide. So primary endpoints like non-fatal MI, fatal MI, stroke, coronary revascularization, cardiovascular death. Next slide. So demographic data. Next slide. Next slide. So effects of trial regimen on CV events. The patient who are statin intolerant, there is 13% reduction in MACE. There is 15% reduction in 3-component MACE. There is 23% reduction in MI, 19% reduction in coronary revascularization. Next slide. So clear outcome, the LDL reduction is 21% and HSCRP reduction is 22.2%. Next slide. Next slide. So clear outcome study conclusions show that bempedoic acid is a first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction in MACE events in patients who are high risk for CVD and documented statin intolerance with elevated LDL cholesterol. Next slide. So bempedoic acid has an effective alternative for statin intolerant patient, like it is well tolerated. It causes reduction in LDL and HSCRP. It achieves primary and secondary endpoint, and it has got a very effective approach on cardiovascular events. Next slide. Thank you.
So there are few questions online. Since this program is running online, so I would like to express few of the questions which are being asked here. Just give me a second, sir. So this from our end would like to ask, first question is, how frequently you see statin intolerance in your day-to-day practice?
India is a hub of high diabetic patient and dyslipidemia, and there are so many patients who are on statin and they are having many complications of statin like muscle pain, myopathy, but they don't report. And the statin tolerance or intolerance is very unreported thing. I think scientifically, if you count the patients, it is very high, like 15 to 20%. But we don't report statin intolerance in our population. But patients do complain about muscle pain and the intolerance to the statin, and many patients stop taking statin because of complications like side effects. So we should always have an alternative to statin, and I think bempedoic acid is a landmark drug for that.
Thank you so much, sir. Next question is, like you initially mentioned about ESC 2019 guidelines, which are getting stricter and stricter day by day. So what LDL cholesterol target you set for your patients? Of course, you stratify your patients according to the risk which is available, but normally what LDL cholesterol goal you set for your patients?
Before ESC 2020, my target was less than 120 or 100. But after ESC, I have learned in harder way that lower is the better, because I have seen patients who were giving statin, but they developed stent thrombosis in spite of giving high dose of statin. So I think there should be no target. Lower is the better. And if patient is very high risk, achieve less than 50.
Sir, is there any neurological complications you see when LDL cholesterol is brought down to 30 milligram per deciliter like that?
Till now, I'm not seen, but there are patients reported. There are cases reported of a neurological complication in international data, but it is very, very few. And I have not seen yet a neurological complication due to lower LDL cholesterol.
So I heard that when a baby is newborn, the LDL cholesterol for that baby is 30 milligram. There's an interesting case which was presented that patient was PCSK9 deficient patient found in USA. Her LDL cholesterols were quite less, 15 milligram per deciliter. So there was an interesting story. And then that patient was also survived for quite a long time. So what is your take on PCSK9 and then how much bempedoic acid will come into picture? Because PCSK9, of course, is a costlier option.
When PCSK9 was discovered, there was a lot of talk. We were very happy. But if you see the affordability, the acceptability of Indian population towards injectable drug, it is very less. So there has to be a drug which is easily available, orally available, and easy to use. So PCSK9 is there, but it should be used preciously, very in selective patients. But bempedoic acid will be very good choice in the patients who are not a choice for injectable therapy. Okay.
Thank you so much, sir. Next question is about, this question is about my patient is a diabetic patient. He's also hypertensive patient. But what LDL cholesterol should I target for this kind of patient? How you calculate? Because in day-to-day practice, calculation of ASCVD risk factor is very important. So how you calculate that factor?
The ASCVD risk score calculator is available on various downloaded things. But if you don't have ASCVD risk score calculator, a simple basic formula: if patient is diabetic and hypertensive, HU less than 90. If patient has underwent a cardiovascular procedure, try to HU less than 50. That's the thing.
That's correct. That's correct. And how safe in CKD patient, bempedoic acid? How safe in CKD patient?
CKD patient. Okay. Till date, I have not used in CKD patient. But if you see the half-life metabolism, around 60 to 70% drug is excreted or excreted by the kidney. So I think in stage 1 and stage 2 CKD, it will be easier to give, but not in stage 3 and stage 4 CKD.
Yes, thank you, sir. This was the last question from the audience. Would like to have your final comments before we conclude this session.
Okay. India is a hub of dyslipidemia patient. We are a population, hugely grown population with diabetes, hypertension, IHD is rampant in our country. We are seeing patients of coronary artery disease at very young age, like 30, 40. Okay, so there should be a drug which is available orally. There should be drug which is available which doesn't cause intolerance, which doesn't cause side effects. I think bempedoic acid will be an easier tool for those patients.
It was indeed a pleasure having you on this ClearTalk session and clearing all our doubts on bempedoic acid. And your in-clinic expertise and experience will definitely help all our delegates to imbibe the practice of bringing LDL cholesterol as per the recommendations, as per the guidelines, more strictly. And of course, bempedoic acid is going to get a helping hand in this bringing LDL cholesterol down in day-to-day practice. Thank you so much, sir. I thank all the delegates for joining this scientific clear talk. Thank you all once again, and would like to wrap up this session. If you are having any questions, you can also comment your questions in the session. We'll come back to you by directly asking sir whenever we can able to touch and come in contact with through email IDs or mobile contact. Thank you.
Thank you, Zydus.